I am going to be presenting on dental hygiene and the need for orofacial myofunctional therapy. The purpose of this presentation is to educate hygiene providers on the importance of orofacial myofunctional therapy and its relation to dental hygiene. With proper training, dental hygienists can promote not only airway health, but reduce the risk of periodontal issues that come along with mouth breathing, clenching, and facial tension. Patients with improper airway health or that are chronic mouth breathers may be at a higher risk for caries and periodontal disease. In patients that are not training their tongue properly, rugae is more pronounced, gag reflex reactions are higher, and scaling for hygienists may be more difficult. In patients with airway issues, oral defensiveness becomes more prominent. Radiographs become more difficult to take due to improper tongue position, leading to a higher gag reflex. Is this recent? The answer is no. The importance of orofacial myofunctional therapy dates back to 1918 when Dr. Alfred Rogers studied the positioning of facial muscles and the need for proper training to naturally align said facial muscles to even allow for less need for orthodontic treatment. In conclusion, proper training and knowledge in airway health will aid us in being proficient clinicians and allow us to build a trusting relationship with our patients and additional providers. We strive for full systemic health and consistency, which is why we need to educate our patients. Adding airway health assessments to our patients' initial visit will benefit them and allow us to get a complete look at their oral systemic health. Now for some research or frequently asked questions that I stumbled upon. What is orofacial myofunctional therapy? According to the Academy of Orofacial Myofunctional Therapy, OMT is the study and treatment of oral and facial muscles as they relate to speech, dentition, chewing and bolus collection, swallowing, and overall mental and physical health. It's the re-education or repatterning of facial and oral muscles. What is an orofacial myofunctional disorder? It's a disorder when the jaw, lip, or tongue aren't in a normal resting position. What does an OMD affect? Sleep apnea, facial and skeletal growth, development, breathing, chewing, swallowing, speech occlusion, posture, TMJ movement, oral hygiene, stability of orthodontic treatment, facial aesthetics, restricted facial and lingual frenum, head posture, incorrect oral habits, and much more. What does OMT have to do with oral hygiene? Everything. We're providers and we're trained to help our patients have optimal oral hygiene, but sometimes we can't do that without the proper screening. What are some signs that a patient might need OMT? Tongue tie, tongue thrust, mouth breathing, speech problems, open mouth chewing, GERD, clenching and grinding, history of orthodontic treatment, and more. Now, some statistics that I found during my research include, according to the National Health and Nutrition Examination Survey from 2015 to 2019, approximately 45.8% of children aged 2 to 19 had caries, treated or untreated. According to Delta Dental's State of America's Oral Health and Wellness Report, 70% of adults believe that oral and overall health are connected, but rate their oral health care below their mental and physical health. 1 in 10 parents are taking their kid to the dentist for an unexpected reason related to cavities, crooked teeth, and halitosis. And there was a 4% decrease in dental visits in children from 2023 to 2024. According to the American Speech Language Hearing Association, tongue thrust occurs in 5.2% to 62.3% of school-aged children, and chronic mouth breathing rates vary from 10.1% to 15.9%. Now, the American Association of Orthodontics states that based on the 9,596 member database of AAO's active and life members, the estimated number of total patients in active treatment across members in the United States and Canada is approximately 5.51 million. In 2022, United States AAO members, which is about 9,160, were treating an average of 344 patients aged 8 to 17 for a total of approximately 3.15 million patients. That equates to about 7.4% of U.S. children aged 8 to 17, which was up slightly from 7.3% in 2018. Lastly, according to the American Dental Association, a survey showed that more than 70% of dentists noticed signs of teeth grinding and clenching in their patients, and more than 60% noted problems with the TMJ. Now, I say this because there were a few studies done recently about braces and proper muscular training, but one that really stuck with me was a study that was done over 30 years ago, which was done on rhesus monkeys for the first 6 months of life and demonstrated the blockage of nasal passages that led to narrowing of dental arches, decreased maxillary arch length, and increased anterior facial height, as well as anterior crossbite and maxillary overjet. These orofacial muscles included the genohyoid and genioglottal muscles of the tongue, the suprahyoid dorsal tongue fibers, the upper lip elevators, and the digastric muscles, and they're shown to be abnormal in monkeys with a nasal obstruction. This is important to note because with the increasing rate of children needing braces, their facial muscles and their bone pattern aren't lining up. Now, the correlation between dental hygiene and orofacial myofunctional therapy. So what's the correlation? According to the ADHA, the overlap is prominent. They state facial muscle dysfunction and mouth breathing increase the incidence of plaque in patients, and lip ties and malocclusions can make some more likely to develop periodontal disease. For example, if you notice tongue tie during an EO-IO exam, check for tongue thrust or any swallowing issues. From there, note the patient's caries risk. This might be due to improper food movement caused by limited range of motion of the tongue. Lack of food movement leads to improper swallowing, leading to a higher risk of decay from plaque accumulating on the teeth. What is our role? In the world of orofacial myofunctional therapy, dental hygienists play a crucial role. Intraoral, extraoral exams, that's where we start. Notice the patient's breathing. Is it through their nose or their mouth? Is the patient sitting in the chair with their mouth open, or do you see them breathing through their nose? For the oropharyngeal region, focus on the tonsillar space. Sit your patient in a neutral position and have them stick out their tongue without saying ah, and note the Ballin-Potty score. I have a picture on the top of the slide showing class 1 through 4, where the soft palate, the fauces, the uvula, and the pillars are all visible, to class 4 where only the hard palate is visible. Note their hard palate. Do they have rugae? Do they have tori? How prominent is their rugae? Try to measure how wide or narrow the palate is with a cotton roll. They're usually about 37 to 39 millimeters long. Do they have tori? Maxillary, mandibular? Clenching and grinding might cause so much pressure and strain that it could stimulate bone growth. Their lips. Is there any strained or chapped lips? We all know the facial muscles, so how about the mentalis muscle or the pouty muscle? It elevates the lower lip and causes strain. Chapped lips are a sign of mouth breathing. Now for the tongue, is there a range of motion? Is tongue tie present? When you do your oral cancer screening, are they able to put their tongue to the roof of their mouth, or do they have to close their jaw to reach? The floor of the mouth. Where does the lingual frenum sit or attach? Is it the floor of the mouth or the alveolar ridge? Where do we go from here? I'm sure everybody has seen these types of assessments in their daily lives in their office. We have our caries risk assessment, a periodontal chart, our notes, but there's an airway health assessment that we can do for our patients every time they come in. Check if they're mouth breathing. Do their lips look strained? Do their tonsils show, or are they class 1 or class 4? Do they have tongue tie? Is there any signs of wear on their teeth? And do they have a narrow palate? Those 6 things are some of the red flags for sleep disordered breathing, or note that we might need to include some therapy in the patient's treatment. The caries risk might be higher in a patient because they do have tongue tie. The periodontal risk assessment might be higher because the patient has tongue tie and might be pulling on their gum tissue. Including these assessments in our patient treatment is crucial, and we have to document everything. As providers in the dental world, we have the opportunity to increase our patients' quality of overall health just with some simple steps. It's our job to educate not only our patients, but ourselves. The world of dental hygiene is constantly evolving, and we have the opportunity to truly provide a higher level of care for our patients. We have a chance to help them live a better life, and it can start in the dental chair.